Assalamu alaikum. Welcome you all to today's CME on third pillar of elimination of cervical cancer prospect in Bangladesh. This CME is jointly organized by OGSB and Labaid Cancer and Super Speciality Hospital. I am Dr. Sadia Sharmin, working as Associate Professor, Department of Clinical Oncology, Bangabandhu Sheikh Mujib Medical University will moderate session. This session will be chaired by Mr. Shakib Shamim, Managing Director, Labaid Cancer Hospital and Super Speciality Center. And Chief Guest will be Professor Dr. A.H.M. T.A. Chaudhuri Sir, President, Gynaecological Oncology Society of Bangladesh and ex-President of OGSB. In this CME, there will be two panelists, Professor Dr. Ferdowsi Begum, President, Obstetrical and Gynaecological Society of Bangladesh, Professor Bardem and Ibrahim Medical College, and Professor Dr. Alia Shahanaz Madam, Senior Consultant, Clinical Oncology, Labaid Cancer Hospital and Super Speciality Center, and Department of Radiotherapy, Dhaka Medical College and Hospital. Madam is working as Vice President of Bangladesh Society of Radiation Oncology and Joint Secretary of Faculty of Radiotherapy of BCPS. In this CME, Professor Dr. Sabira Khatun Madam will be our special guest, Founder Chairman, Department of Gynae Oncology, Bangabandhu Sheikh Mujib Medical University, Secretary General, Gynaecological Oncology Society of Bangladesh, Senior Consultant, Gynae Oncology, Labaid Cancer Hospital and Super Specialty Center. And within us, Professor Dr. Kaji Mustaf Hossain Sir will be our chief special guest, Senior Consultant, Clinical and Radiation Oncology, Labaid Cancer Hospital and Super Specialty Center, ex-Director of National Institute of Cancer Research and Hospital, and President of Bangladesh Society of Radiation Oncology. Now I am introducing our first keynote speaker, Professor Dr. Parveen Akhtar Banu Madam, Senior Consultant, Clinical Oncology, ex-Chief Consultant, Delta Medical College and Hospital. I am requesting our first keynote speaker, Madam.
Thank you, Sadia Sharmin. So today, Shakib Shamim and highly respected Professor Dr. Sabira Khatun Madam, Professor Dr. Kazi Mustaq. Assalamu alaikum to all, and I welcome you all to Prospect in Bangladesh.
Yes, madam. Yes, madam.
Thank you. So topic is carcinoma, basic like incidence and human papilloma. So key facts is cervical cancer is second most common cancer in women, with an estimated more than 420 reported by IARC. About 90% of countries. And as we know that cancer cervix 84.6 in Eswatini. This is a African country. 55.7 in Eswatini. Malawi, Zambia rate is high. So two human papilloma virus, as we know, 16-18 are responsible.
Slide shift হচ্ছে না
The slide তো এটা শেষ হয়নি
একটা শেষ হয়নি তো
স্যার যাচ্ছে
হ্যাঁ
ওই যে নিচে আলাউদ্দিনের চেরাগ
এটা না ফুল
ওই যে কাপের মতো যেটা
দেন না
থ্যাংক ইউ
So HPV screening and treatment of precancerous lesion is cost effective way to cancer control includes primary prevention, that is vaccination against HPV and palliative care. HPV and cervical cancer infection. Although most HPV infection clear up on their own, become chronic and precancerous lesion progress to invasive cervical system. It can take up to 5 to 10 years in women with incidence in Bangladesh, according to International Agency for Research on Cancer, more than 50 million 1,686 new cases and 10,362 deaths occur. Has a high burden of cervical cancer due to the lack of screening, high prevalence multiparity, sexually transmitted diseases, and low socioeconomic conditions. We can see the incidence of different cancer. This is hospital-based registry. And lung cancer, head, neck, breast, lung cancer are the most common. Breast is going very high. And other cancers. And I started just 523 patients of carcinoma cervical counted here. And age incidence, we can see that most commonly 31 to 40 highest incidence, and then 51 to 60 years of old women are the affected group. Confined to the cervix stage on, when it goes beyond cervix, it is stage 2. It has also or walls of the pelvis. It stage 3, when it goes to the neighboring organs like rectum, bladder, or beyond, and other organs. National strategy for cancer prevention and control 22, there was a strategy adopted by WHO and also with the help of BSMMU and UNFPA, I think. Scaling up HPV vaccine to girls aged 19 to 13 years and augmenting cervical cancer early screening and treatment programs and strengthening palliative care services or expanding educational campaigns for cervical cancer control are some of the key elements from the newly developed strategy for fighting cervical cancer in our country. All women between 30 to 60 years of age are considered for screening. A population estimated by the last national census in Bangladesh is 30 million persons. Now, cervical cancer control comprehensive approach. Primary prevention is girls 9 to 14 years should be given HPV vaccination. Girls and boys should also be offered as appropriate health information and warnings about tobacco use, sex education tailored to age and culture, condom promotion and provision for those engaged in sexual activity, and male circumcision. HPV vaccine work best if administered prior to exposure to HPV. Therefore, to prevent cervical cancer, World Health Organization recommends vaccinating girls aged 9 to 14 years when most have not started sexual activity. Some countries have started to vaccine boys also. HPV vaccination does not replace cervical cancer screening. In countries where HPV vaccine is introduced, population-based screening programs are needed to identify and treat cervical precancer and cancer to reduce cervical cancer incidence and deaths. Okay. Secondary prevention from 30 years of age, In India, they start earlier. For women from the general population should start regular screening with a validated HPV test every 5 to 10 years and from 25 years of age for women living with HIV. The process for a healthcare provider obtaining a cervical sample is similar with both cytology and HPV testing. However, who suggests that self-collected samples can be used when providing HPV DNA testing, followed by immediate treatment or as quickly as possible after an HPV molecular positive test. This is just a picture to show how normal cervix may be smooth and lusterful, but then low-grade CIN changes comes, then high-grade, then cancer. Now, tertiary prevention, which we are going to talk about in details today. All women as needed should be included. Treatment of invasive cancer at any age and treatment available, first choice of treatment surgery, then radiotherapy, chemotherapy, and then palliative care. Symptoms, we should know talk about something. Symptoms, early cervical cancer symptom may be regular blood spotting or light bleeding between periods in women of reproductive age, postmenopausal spotting or bleeding after sexual intercourse, and increased vaginal discharge, sometimes foul smelling. In more advanced stages, persistent black stool, leg or pelvic pain, weight loss, fatigue, loss of appetite, foul smell discharge, vaginal discomfort, swelling of leg or both lower extremities. Other severe symptoms may arise at advanced stages depending on which organs the cancer has spread to. Now, pre-treatment evaluation, as we know, complete physical and gynecological examination is must. CBC, biochemistry, urine analysis, chest X-ray, ultrasonogram, CT scan, MRI of abdomen, pelvis, sometimes PET CT scan, biopsy, punch knife, colposcopy guided or colonization, cystoscopy, barium enema, sigmoidoscopy, IVU, if bladder, rectal, or ureteric involvement is suspected. Treatment of cervical precancer. Treatment of precancer is ablative treatment with cryotherapy or thermal ablation. Both parameters are equally effective and safe and can be performed in an outpatient clinic. In case of non-eligibility of for ablative treatment or where there is suspicion of cervical cancer, women need to be referred to the right level of health scopy and biopsies. Excision treatment, and in case of cancer, an individual treatment plan is designed depending on the stage of the disease. Now, here is a guideline of treatment management of cervix cancer, ESMO guideline 2022. If colposcopy and biopsy is done, then if it is CIN 2, 3, conization, and if invasive cancer, then early stage, if it is early stage, FIGO on A, then simple hysterectomy, no LVSI, then simple hysterectomy, frozen section if frozen section done, equalization only if negative margins, biopsy if negative margins, pelvic lymph node dissection or parotid lymph node dissection or trachelectomy. These are the options of the treatment they have outlined. Earliest stage, FIGO stage on A2, radical hysterectomy, simple hysterectomy, trachelectomy plus PLND plus PLAND, sentinel lymph node biopsy. FIGO stage on B2, 2A, radical hysterectomy plus PLND, PLND, sentinel lymph node biopsy, and trachelectomy or concurrent chemoradiation gives equivalent result with surgery. And locally advanced cancer, like on B2, 2B, 3B, then concurrent chemoradiation. Tailoring of radiation according to surgical staging or PET CT, NSCT followed by surgery or radiotherapy. FIGO stage 4A, chemotherapy or combination concurrent chemoradiation or pelvic exentration. Given the outline, what we can on the treatment may be given. So histology, as we know, mostly 80-85% cases is squamous cell carcinoma, either keratinizing, non-keratinizing, and about 10 to 15% also small depends dimension of the tumor, stromal invasion, depth of wall involved, tumor differentiation, LVSI, status of resection margin, status of parametry and vaginal cuff, and number and status of lymph nodes. These all parameters we have to look into to fix the adjuvant treatment, to decide the adjuvant treatment. Intermediate risk disease. Intermediate risk disease is characterized by the presence of the following risk factors: tumor size more than 4 cm, deep stromal invasion, LVSI. As a significant progression-free survival and overall survival benefit has been shown with postoperative RT in women with deep cervical stromal invasion. And high-risk disease is characterized by the presence of one or more negative prognostic factors such as positive or closed surgical margin, positive lymph nodes, microscopic parametrial involvement. Adjuvant concurrent chemoradiation is recommended for patients with high-risk disease. Adjuvant CRT is associated with better overall survival and progression-free survival than adjuvant RT for patients with stage 1A, 2, 1B, and 2A disease, particularly for those completing 3 to 4 cycles of cisplatin and 5FO. This stage 1VA to stage 2A surgery may be done, and radiotherapy with concurrent chemoradiotherapy. The latest randomized controlled study, URTC 55994, confirmed that the efficacy of NSCT followed by surgery is similar to that of concurrent chemoradiotherapy in patients with stage 1B2 to 2B cervical cancer, with no difference in 5-year survival, that is 72% and 76% respectively. Now, lymph node staging and RT. Lymph node staging for patients with locally advanced cervical cancer, pelvic MRI and clinical examination essential to determine the local extent of the tumor for both external beam radiotherapy and brachytherapy planning, as we know. Information on periodic nodal status is also essential for treatment planning. As we can see here in advanced stage, that is stage 2B, 3B, we do see the periodic evaluation of periodic lymph nodes. If negative, then radiation, concurrent chemoradiation, we advise to the patient. If periodic lymph node positive, then we can evaluate with PET scan also. Periodic lymph node is better, can be evaluated with PET CT scan. Then we give extended field radiation concurrent to weekly cisplatin, and or neoadjuvant chemotherapy 3 cycles, then followed by extended field RT. This is our TrueBeam linear accelerator in Labaid Cancer Hospital, which is the latest machine delivering all types of high sophisticated treatment, 3D, IMRT, and VMAT, and SBRT, IGRT, all types of treatment we can do with this latest machine from the Varian. This is our machine in inauguration a few months back, second machine, second LINAC. And this is brachytherapy part. After external radiotherapy, 5 weeks, 46 to 50 gray, then we give brachytherapy. As we know that brachytherapy is integral and very important part of treatment in cervix cancer, and without brachytherapy, patients are not cured. So we do brachytherapy for all cervix cancer patients. who are eligible for it. And it can be done with LDR, MDR, SDR, that is low dose rate, medium dose rate, high dose rate. I have done LDR for years, from 1996 to 2010 in Delta Hospital. I used cesium treatment, but difficulty is that patient in a isolated room for 20 to 24 hours. In a same, we have 8 high dose rate, which delivers more than 12 gray per hour, and practically much higher dose than rate is used, dose rate is used, and it is very convenient. Within few minutes, treatment is completed. This is remote after loading. All the randomized trials comparing low dose rate and high dose rate, the results are equal. So how do we, this is 2D treatment, extended field radiotherapy, and we give midline block just to shield rectum after 40 gray is completed, so that we can give a brachytherapy, because brachytherapy rectal dose should not be exceeded to certain limit. So we protect rectum after certain doses, certain fraction of treatment with MLB. And this is 2D brachytherapy. We can see here that these two ovoids in the fornices, vaginal fornices, and central tandem inside the uterine cavity. This is intracavitary brachytherapy. Brachytherapy can be several types, like intraluminal, intracavitary, interstitial, and implantation, many types. So this is intracavitary brachytherapy we are doing here. So these are isodose, that means the radiation doses which are same, and these points which receive same doses, we call this isodose. And this plotter is showing that this patient is getting brachytherapy so nicely. And beauty of brachytherapy is that rapid fall of radiation doses from the source, near the source it may get 150 to 200% of radiation, but rapidly it falls, so that neighboring organs, rectum, bladder, does not receive much, as we cannot save with external radiotherapy as we can do it with brachytherapy. So these are the isodose lines we are seeing here, and this is the bladder we can see far away, and this rectal marker, rectum is there, and bladder is there. This is all 2D, two-dimensional treatment. Now, after effect of brachytherapy, external and brachytherapy, we can see that MRI shows very nicely after 5 years follow-up how nicely the so big a tumor has shrinking down, and now the patient is doing well. This is our latest brachytherapy machine, Saginova, here in Labaid. We are using for almost 1 year. We are using this brachytherapy machine for brachytherapy treatment of our gynecological cancer. And this is the room where we treat brachytherapy. This is our insertion table tray, and this is our machine. And this is our young doctors. Very nicely, they are doing brachytherapy. There is a team of doctors, nurses, and sonologists also. And these are the applicators. So these intrauterine applicators you can see, and this void tandems, and you know, and then in furnaces we introduce simulation transfer to the parameters and whether we are giving, we are not exceeding our dose limits so that organ at risk should not have excess toxicity, immediate or late toxicity. So we have guidelines, all the detailed guidelines to treat this type of cases. So this we are shifting to 3D image guided brachytherapy. Here nicely you can see that all the tumors in the cervix are not round shaped. They are, they have many corners. They can extend to parameters, on parameters, and they can go to vagina. So this is bizair shaped tumors usually. So here, if we do CT guided or MRI guided brachytherapy, then we can draw the tumor. We can draw the gross tumor volume. Then we can draw the high risk tumor volume, that is subclinical extension beyond gross tumor. Then intermediate risk CTB, and then we treat the target area, and we can treat also the organ at risk. We can see the doses, whether our dose limit is exceeding or not. Like before in ICRU 38, we had a rectal and bladder a reference point, but reference point is not actually showing us that OAR is reaching the actual doses. We cannot see. Maybe other parts of the bladder or rectum, as here it is shown, receiving much more doses. Maybe it is very close to the uterus, there is adhesion or some other factors. So here we can see that how we can draw and then treat accurately. Here, example, we can see the tumor maybe pink color. You can see that we are treating tandem and ovoids like this, but tumor may not be round, is not usually round, and there may be a parametrial extension like this. Then we can introduce a needle there, and then we can bring our isodose in that, to include that part of the tumor. So we can treat the whole tumor as a whole, but in point doses like point A and point B we used to treat previously, there are some limitations to treat. We can we can prescribe dose to point A and B, but all the tumors may not be included in our treatment field. So intracavitary brachytherapy, interstitial, this needle insertion, we say it interstitial brachytherapy and or hybrid brachytherapy. If we can introduce a needle like this with tandem and ovoids, central tandem and ovoids, then it is hybrid brachytherapy. In MRI, we can see here that how we can bring our isodose, that is 60 gray isodose line we have brought in, elongated shaped with insertion of a needle in the parametrial region. So there is guidelines, J. Castro working group definition, how we should treat and how dose is defined, and rectum bladder, how we should report our treatment, and 1 centimeter, like 2 centimeter, 5 centimeter of OAR doses, and DVS of bladder, rectum. This all is documented, should be documented during treatment, and if it is within acceptable limit, then we can treat only. This is interstitial brachytherapy I have done in my previous hospital. These are all needles, you can see. If there is parametrial disease, then we can introduce the needles to that area. After seeing CT and MRI, we can plan how should we introduce our needles, and then we can build up doses to that that area, tumor bearing area. And this is our interstitial brachytherapy plan. You can see the needles and immediate vicinity of the needles. There are, lot of, you can see the high buildup of doses, and immediately after, beyond that, dose follow-up is rapidly, dose falls up. immediate vicinity, you can see that those color code is here, red area, and 150 to 180 immediate vicinity of the needles. But after that, dose falls very rapidly, and in the last green one, it's showing only 75% of the doses. Optimization, we can do also needles after insertion. We can see if the tumor is covering or not. If it is on or two needles, we can our goal is minimum dose to 90% of our target tumor target volume of HR scrap dose should be more than 90%, and GTV should receive more than 87 rate HR CTV, and 2 cc bladder, 2 cc rectum, 2 cc sigmoid. These should these are the dose levels we should achieve, and not beyond that. That may cause toxicity. So we have everything, every guidelines to do this kind of treatments. So this slide I am showing. We have done a phase 2 study, international study. I participated in this study. This is a the study was done in the under the Forum for Nuclear Cooperation in Asia. And started 5 IGBTs ongoing. So this is 4, and this study was 2B, 3B, and patients inclusion criteria was pelvic lymph nodes should be there in CT scan, but no para-aortic lymph nodes. But prophylactic para-aortic radiation we used to give. So we treated 6 weeks, and then concurrent chemoradiation. After 3.5 weeks MLB, and then we started para-aortic lymph node treating. Then 4 doses of brachytherapy. Usually we give 3 courses of brachytherapy weekly, but here 4 courses.
Madam, we are running short of time.
We are just closing. Yeah, these are the countries we participated in this study, and here is our result. And we had a local control of 91% and overall survival 77%, and progression-free survival 70%. And it was published in a very highly reputed journal, Radiation Oncology, Biology and Physics, Red Journal, in 2019. And survival is, we know, stage on and B. When it comes to stage 4, it is 9.3% in cervix cancer. So this is our daycare, 30 bedded in our Labaid Cancer Hospital. This is our modular OT, and thank you very much for your kind attention.
Thank you, madam, for your nice and elaborative presentation. In the meantime, our chief guest, Professor Dr. A.H.M. T. Chaudhary, sir, has been joined. Sir, assalamu alaikum.
Walaikum assalam.
Yes,
Thank
sir.
you very much for inviting me. But the problem is the time is quite short. There are Maghrib prayers and I have to go before that. So maybe sometime I can talk a few words. You may continue with the program, but I may have to go. Thank you. You continue.
Thank you, sir. With the permission of our chief guest, I want to invite our second keynote speaker, Professor Dr. Mohammad Ehtishamul Haq, sir, Senior Consultant, Radiation and Clinical Oncology, Labaid Cancer Hospital and Super Speciality Center, ex-Director, Admin, Anwar Khan Modern Medical College Hospital. Professor Dr. Mohammad Ehtishamul Haq, sir.
Respected colleagues of OGSB and Oncology Society, my grateful thanks to our respected professor T.A. Chaudhary sir. Actually, he is teacher of all of us, and we are proud to say something in front of him. Actually, my part is systemic treatment of cervical cancer, and I want to thanks my senior colleague Parveen Akhtar Banu madam, who is one of the authority in the treatment of cervical cancer in Bangladesh. She makes my job much easier with her presentation. So without further delay, I am moving. Actually, this slide was presented by madam earlier, where madam shown the stage-wise treatment of the cervical cancer. I will just touch where the systemic treatment we will consider in the management of the cervical cancer patient for better overall survival and progression-free survival. Here from this slide, which is a small guideline for the management of the cervical cancer, nicely madam shown that figure 1 and 2 of early disease cancer, we need actually adjuvant treatment for the high-risk patient, as well as in the figure 1, 2, 3 of locally advanced disease, as well as figure 4A, chemotherapy and concurrent chemoradiotherapy is the treatment of choice in the management of the cervical cancer. As all of we know that radiotherapy and surgery is the mainstream of treatment of the cervical cancer management. But in the new era of oncology, where systemic therapy is helping in many aspects of management of the oncology, so in the management of the cervical cancer as well, systemic therapy is now playing a great role. Almost what I have figure 4 as well as figure 4B, systemic therapy is playing an important role. Just next slide. Why not moving? Hey, এটা মুভ করতেছে না, ওকে ডাক দাও। এই মুভ করতেছে না তো স্লাইড। Sorry for the technical difficulties. Okay. So this is very busy slide. Here actually what I want to show that ESMO already give us the final guideline that chemo adjuvant treatment of advanced and metastatic disease, we need this systemic therapy. And if we go for to see the NCCN guidelines, especially in 2023, they have actually reviewed all the aspect of the systemic treatment of the cervical cancer. The important one I will show later. I am now proceeding the next slide, where we can see that in 1B1 to 1B2, 2A1 and 2A2, the mainstream of treatment is either surgery or radiotherapy, but the systemic treatment with concurrent platinum containing chemotherapy is playing very important role in giving overall survival and progression-free survival. And the next slide, we can see whether there may be node negative or node positive and periodic lymph node positive cases. The concurrent chemoradiation with cisplatin-based chemotherapy is playing important role. And if we go in stage 1B3, 2A, stage 3, 2B, 3, and 4A, what we have shown in the ESMO guideline, here also NCCN is recommending that concurrent chemotherapy with platinum-containing agent is one of the important tools of management of this cervical cancer with radiation or surgery. I want to skip here also. I want to skip this slide. Here also we can see pelvic lymph node positive case or para-aortic lymph node positive case. Either we are doing surgery or not, there is important role playing with concurrent platinum chemotherapy in every steps of the management. And again, stage 1A and 2B, where incidental findings of simple hysterectomy, concurrent chemotherapy is also playing important role. And again, in stage one, findings of invasive cancer after simple hysterectomy, we will actually using platinum containing chemotherapy with the other tools of management. If there is local or loco-regional recurrence, then again, whatever may be the other procedure, but the systemic therapy and concurrent chemotherapy with platinum base is playing important role in the management of local and regional recurrence of cervical cancer failing after primary treatment. Stage 4B, what I have told earlier, where distant metastasis is there, then systemic therapy is the only management, but in amenable to local recurrence, we can do some local treatment as well as with systemic therapy. Now this is, we know that some of the cervical of the cervix we are having now, and this type of patient, actually, we need chemotherapy with cisplatin, etoposide, or carboplatin with chemoradiation in all stage of this small cell neuroendocrine carcinoma of cervix. So now I am moving. What are the agents actually we are using in the management of cervical cancer? Preferable regimen is cisplatin, carboplatin. When cisplatin is not tolerant for the patient, so we will use cisplatin. In the first slide, what I have tried to show that now actually NCCN recommended that pembrolizumab immunotherapy also is one of the important agent we can use with bevacizumab in the first line therapy of cervical cancer. Other recommended agent is cisplatin, carboplatin, paclitaxel, bevacizumab, topotecan, and second line agent we can use again pembrolizumab and bevacizumab, paclitaxel, albumin-bounded paclitaxel, docetaxel, fluorouracil, gemcitabine, pemetrexed, topotecan, vinorelbine, and irinotecan. And now some are new drugs coming like nivolumab and some other immunotherapy also we are having in the management of the cervical cancer. One thing I missed here, that in neuroendocrine tumor, we will also using now atezolizumab in the management of the neuroendocrine cervical tumor. So I am now closing my presentation again with showing these. First line, we know that we are using cisplatin and paclitaxel as well as ifosfamide in earlier days. Now in second line, we are using bevacizumab, topotecan, vinorelbine, gemcitabine, albumin-bound paclitaxel, docetaxel, prazopinib, and pegylated doxorubicin. So I want to say thank you for the organizer of Labaid Cancer Hospital and OGSB for giving me the chance to say something over systemic therapy of the cervical cancer. Thank you very much.
Thank you, sir, for your nice presentation on systemic treatment of in the management of cervical cancer. Now I am requesting our third speaker, Dr. Mosammad Farhana Taranum Khan, Assistant Professor, Department of Gynaecological Oncology, National Institute of Cancer Research and Hospital. Dr. Mosammad Farhana Taranum Khan.
Assalamu alaikum, and thank you for inviting me.
Madam, screenটা একটু শেয়ার করুন।
Is my slide visible? Is my slide visible?
Not
No.
yet.
Not yet.
স্যার আপনার স্লাইড শেয়ারটা কি বন্ধ করবেন?
হ্যাঁ, আমারটা বন্ধ হচ্ছে। আমারটা বন্ধ হয়ে
আচ্ছা
গেছে।
ঠিক আছে। এখন মনে হয় এটা হচ্ছে হ্যাঁ জি
Is it
আপনার স্লাইড
visible now?
না এখনো ভিজিবল না ম্যাডাম। আপনি এখন
আমারটা
শেয়ার
বন্ধ।
করেন স্ক্রিন।
আমারটা বন্ধ।
আমি কিন্তু শেয়ার করেছি।
আচ্ছা ওইখানে আমাদের টেকনিক্যাল সাপোর্ট দেওয়ার কেউ নাই ম্যাডামের ওইখানে?
কেউ
না এখানে কেউ
না
নাই।
এখানে
আমি
ম্যাডাম আপনি একটু স্ক্রিন শেয়ার অপশনে আপনার ওই ইয়েটা করেন।
হ্যাঁ আমি স্ক্রিন শেয়ারে দিয়েছি।
দিয়ে
ম্যাডাম
তারপর
আসে
আপনার
নাই।
প্রেজেন্টেশনে যেটা আছে ওইখানে ক্লিক
হ্যাঁ
করতে হবে।
ক্লিক করেন।
হ্যাঁ ওটা করেছি।
তাহলে ম্যাডাম অফ
তারান্নম আপা
করে
আপনি
কি
ক্লোজ করে আবার শেয়ার
ক্লোজ
দেন,
করে
ক্লোজ
হ্যাঁ
করে আবার শেয়ার দেন।
অফ করে
এবার
এবার ঠিক আছে আসছে।
এখন
Assalamu
আসছে।
alaikum and a very good evening. Honorable Chairperson, respected chief guests of honor, and other distinguished dignitaries. This is Dr. Mosammad Farhana Taranum Khan, gynaecologist from National Institute of Cancer Research and Hospital. Today, my topic is surgical management of pre-invasive and invasive cervical cancer. The third pillar of cervical cancer includes এটা চলে যাচ্ছে এটা সমস্যা হচ্ছে এটা তো আমি দেখতে পাচ্ছি না স্ক্রিন এটা sorry for the interruption. The third pillar of cervical cancer elimination program is 90% of women identified with cervical disease should be treated. And the cervical diseases include both the pre-invasive and invasive cervical cancer. That is, the pre-cancer condition should be treated in 90% cases, as well as in 90% of women with invasive cancer should be managed. As my earlier seniors told about the I am going to talk on the pre-invasive and invasive cervical cancer surgical aspects. Relations of cervical cancer. The precursor relations are called dysplasia. CIN1 when the it is also presentation of and this is low-grade cervical intraepithelial neoplasm or LC, where the disordered And in CIN3, this is extending epithelial
Recording
changes.
has stopped. This meeting is being recorded.
And in CIN terminology, it is low-grade CIN, and in Bethesda terminology, it is LC. The mild dysplasia is, as I have told earlier, that it is known as CIN1 or low-grade CIN or LC. And moderate dysplasia, it is CIN2, and it is included in high-grade lesion in Bethesda terminology. Severe dysplasia or SIA, which corresponds to CIN3, and it is also included in high-grade squamous intraepithelial lesion. And carcinoma in situ is also included in high-grade squamous intraepithelial lesion. That is, CIN1 is only low seal, and CIN2, 3, as well as carcinoma in situ is included in high-grade squamous intraepithelial neoplasia. Though cervical intraepithelial neoplasia is a histological term, but popularly in colposcopy, we grade it as CIN2, 1, 2, or 3, depending on the acetohyte lesion seen in the cervix, as well as in other mosaicism or vascular pattern seen in the colposcopy. This is normal cervix, which is looking glazy, and this is CIN1, where the mild acetohyte lesion confined to the transformation zone, and in CIN2, the acetohyte lesion is more deeper, and it is also extending outward from the transformation zone. And in CIN3, here the acetohyte lesion is more extensive, and in cancer we see the growth. Now, what are the modalities of treatment for pre-invasive lesion? The modalities of treatment are ablative or destructive methods and excisional methods. Ablative methods include cryotherapy or cryosurgery, thermocoagulation, and laser ablation, whereas excisional methods include LEEP, that is loop electrosurgical excision procedure, or large loop excision of the transformation zone, and conization. Conization are of two types. One is cold knife conization or CKC, another one is laser conization. What are the preconditions we have to follow before ablative treatment? The upper limit of the lesion should be completely visualized. Whole transformation zone should be seen on colposcopy. There should be no discrepancy between cytology, colposcopy, or biopsy, and there should be no suspicion of microinvasive or invasive disease or cervical glandular intraepithelial neoplasia, and patient should be compliant for follow-up. After colposcopy, we graded the lesion as CIN1, 2, 3, microinvasive lesion or invasive disease. In CIN1, where the abnormal cells are confined to the lower 1/3, mostly requires observation and careful follow-up. And the factors affecting the choice of treatment, whether we should treat the patient or follow up the patient, or whether we should choose the ablative or destructive method or excisional methods, depends on the biopsy report, especially of endocervical curettage report, patient's age, parity, desire for future fertility, pregnancy or postpartum period, availability of the method, and experience of the surgeon, as well as chance of dropout of the patient, and integration among Pap, smear, colposcopy, and histopathology report. In most cases of CIN1, as we all know, that CIN mostly regress to normal cervical smear. So we prefer observation and careful follow-up. But sometimes we need treatment even in CIN1. What are the conditions? When the patient is immunocompromised, if the patient's age is more than 35 years, lesion is large, lesion extending into the endocervical canal, and when the lesion persists more than 2 years, even in CIN1, we have to treat. What are the modalities of treatment? I have already mentioned that observation and follow-up mostly required, and during a this is the cryo gun, which consists of gauze cryotherapy, and this is 3 months after. This is the appearance of the cervix, which becomes almost normal 3, and this is the appearance of the cervix 1 therapy. And patient should be advised that she will have vaginal discharge for 2 weeks, and she has to avoid her intercourse for 2 weeks. Another ablative method is what we commonly use is thermocoagulation. This is a thermocoagulator. It is also used as an outpatient procedure. Minimum discomfort, patient feels minimum discomfort, no anesthesia is required. This is the picture of the cervix right after treatment with thermocoagulation. Here, electric current is applied over the cervix at 100 to 120 degrees centigrade for 30 to 40 seconds. And it can be used even in peripheral centers. Large loop electrosurgical excision procedure. Here, the transformation zone, including the entire lesion, is cut over through a loop. There are different types of loop used for lip, and you see that there are different types of loop, and shape are also different. We usually use loop which is larger than the lesion and covering the entire transformation zone. We can give a single pass or multiple pass for ectocervical lesion. If there is endocervical lesion, we usually use 2 pass lesion, 2 pass, and top hat or cow hat type loop is used here. And conization is another procedure where excision of the entire lesion is done. In conization, the entire ectocervix and also part of the endocervical canal is removed in a cone-shaped manner. Indications are cervical intraepithelial neoplasia extending into the endocervical canal, and better to treat all CIN3 lesion by conization: cervical glandular intraepithelial neoplasia, adenocarcinoma in situ, where unsatisfactory colposcopy along with high seal in pap smear. In case of positive endocervical curettage, discordant cytology and biopsy report, and biopsy consistent with micro-invasive disease. The disadvantage of conization is it cannot be done as an outpatient procedure. It requires hospital admission. It requires anesthesia. There is more blood loss than the other excisional procedure like lip. And there is chance of hemorrhage, and post-operatively there is chance of also cervical stenosis as well as cervical incompetence. We all know the staging of cervical carcinoma, so I am not going in detail through it. And what are the treatment procedures of cervical carcinoma? The cervical carcinoma treatment includes in case of microinvasive lesion, that is in stage 1A, either we can do simple hysterectomy or excisional procedure like conization or simple trachelectomy or radical trachelectomy. But from stage 1B to 2A, we usually perform radical hysterectomy with pelvic lymph node dissection. And from stage 2B to 4B, we usually use concurrent chemoradiotherapy. What are the types of hysterectomy? There are 5 types of hysterectomy. Type 1 or extrafascial hysterectomy. It is also known as simple hysterectomy. Here, parametrium resection is done minimum, and it is usually used for stage 1A1 cervical carcinoma without LVSI. Type 2 or modified radical hysterectomy, popularly known as Bhartim's hysterectomy. It is most commonly practiced where uterine artery is ligated, where it crosses the ureter. The proximal, cardinal, and uterosacral ligaments are resected, and upper 1 to 2 centimeter of the vagina is usually removed. It is usually done for stage 1A1 cervical carcinoma with LVSI, stage 1A2 cervical carcinoma. Type 3 radical hysterectomy or mixed procedure, where uterine artery is ligated at its origin from internal iliac artery, resection of uterosacral ligament at their sacral attachment, and cardinal ligament is removed from the lateral pelvic wall. Resection of upper vagina is done, and it is usually done for stage 1B cervical carcinoma. Type 4 or extended radical hysterectomy, it is usually obsolete nowadays. It is as type 3, but upper 2/3 of the vagina and paravaginal tissue is removed, and ureter is divided from pubovesical ligament and superior vesical artery is ligated. Type 5 hysterectomy, this is basically partial exenteration, very rarely performed. Hysterectomy is usually in radical hysterectomy or hysterectomy done for cervical carcinoma, usually performed along with bilateral pelvic lymph node dissection, and the lymph node dissection is done from circumflex iliac vein to mid-common iliac arteries, that is from femoral ring to mid-common iliac arteries. And removal of the ovaries and tubes are not part of radical hysterectomy per se, but usually we remove both the ovaries and tubes unless there is some indication that is for young patient where the histopathology is squamous type. There are another classification of radical hysterectomy, that is Kaito classification, which was devised in 2008 in the conference, Kaito conference, and it is basically devised by Carlo and Moro. And the origin, what is the difference between these two? Original, what I have told just now, this is Pfeiffer and Ruhl's classification. It was devised in 1974. Type 1 hysterectomy, that is extrafascial hysterectomy, which correlates with the class A Kaito classification, that is minimum resection of the paracervix. Type 2 or modified radical hysterectomy, this corresponds with class B, that is where resection or transection of the paracervix is done at the level of ureter. And type 3 or radical hysterectomy, this is class C, corresponds to class C Kaito classification, that is classical radical hysterectomy. It is of type 2, C1 with nerve preservation, and C2 without nerve preservation, that is preservation without preservation of the hypogastric nerve. And when nerve preservation is done, there is bowel and early movement of the bowel and bladder, and patient's overall function is better. And type 4 is omitted in Kaito classification, and type 5 in original classification is exentation. It is corresponding with the class D hysterectomy of Kaito classification. This is also exenteration. What are the surgical treatment modalities for cervical carcinoma in those patients who wants to preserve their fertility? We know that about 40% of patients of cervical carcinoma are childbearing age. So some of the patients might not have completed their family and they require fertility sparing treatment. For stage 1A1, if it is without lymphovascular space invasion, cervical conization with negative margin is enough. But for those patients where stage 1A1 with LVSI, they require either conization with negative margin, but before that, bilateral pelvic lymph node should be done. Lymph node removal can be done either laparoscopically or laparotomy through extraperitoneal approach. And the lymph nodes should be sent for frozen section biopsy. If frozen section is negative, either cone biopsy with negative margin is enough, or we can do radical trachelectomy. Usually radical trachelectomy is done in stage 1A2, stage 1B1, and in selective stage 1B2. Why radical trachelectomy with BPLND is done. This is the graphical presentation of hysterectomy types. This is cervix. Along the margin of the cervix is removed in simple hysterectomy or type 1 hysterectomy. In type 2 or modified radical hysterectomy, there is mid portion of the cardinal ligaments are removed, medial half. And in type 3 or radical hysterectomy, classical radical hysterectomy, the parametrium is removed from the lateral pelvic wall. This is the picture of radical hysterectomy, where the vaginal margin is removed in its upper 1/3, and parametrium, you see the parametrium is removed, and this is the bilateral pelvic lymph nodes are here. And what is more important, but I have not prepared a slide, that is the follow-up counseling and follow-up. It is required in every step of the treatment, both in precancerous and in cancerous treatment, and both in ablative procedure as well as in excisional procedure, because we have to see the patient at a regular interval, and we have to tell the patient about their follow-up schedule. Thank you all for your patient hearing.
Thank you, Dr. Mosammad Farhana Taranum Khan, for your nice presentation on surgical management of cervical cancer. Now, I am requesting our first panelist, Professor Dr. Firdausi Begum Madam, for very short comment regarding today's CME, as we are running short of time. Professor Dr. Firdausi Begum Madam, President, OGSB, Professor, Bardem and Ibrahim Medical College.
Please remove the slide. Yes, thank you.
ম্যাডাম না থাকলে ওজিএসবির আর কেউ একটু বলুক, তাইলে তো।
না, ম্যাডাম তো ছিলেন স্যার। আছেন ম্যাডাম আছেন।
Sorry, I was praying. I'm back again. আমি নামাজ পড়ছিলাম। Anyway, I'm available now. Assalamu alaikum. Shubho অপরাহ্ন. Very good afternoon to all of you. I really praise the organizer for organizing this event, because most of the time, many of the time, we see that we are doing programs for the policymakers to raise the level of awareness at that level, as well as we go to the field to raise the awareness among the general public. But many often we see that we are not that much aware about the elimination program and the treatment procedures which we need to take. So this is very important to all of us, and all the papers, though I was not present at the event at the very beginning, but the presentations were excellent, and very all-encompassing, I should say. And the presence also is a very good number, and our very respected Professor THB sir is here, sir. Assalamu alaikum, and other dignitaries as well. So basically, I learned a lot about brachytherapy, then chemotherapy, and of course, the other aspect of radiotherapy and surgery, the updates and all this. I think all have been benefited. And OGSB, as part of this, is very happy to not only to endorse it as the participant as well, but we could have more participants that could be enlighten all of us. Hope this kind of activity will continue in future in different forms. Thank you so much.
Thank you, Madam. Now our second panelist, Professor Dr. Alia Shahnaz, Madam, Head of Department of Radiotherapy, Dhaka Medical College and Hospital. Professor Dr. Alia Shahnaz, Madam.
Honorable Chief Guest, Professor T.H. Choudhury, sir, Chair, Mr. Shakib Shamim of MD Labaid Cancer Hospital and Super Speciality Center, special guest, Professor Sabira Khatun, ma'am, and Professor Qazi Mustaq Hussain, sir, and the learned audience, and both the speakers. Assalamu alaikum. Thanks to the organizing committee for giving me the opportunity to speak in this occasion. As we are running short of time, so my speech will be a little bit shorter. I actually congratulate and I highly appreciate the renowned oncologist of our era, Dr. Parvin Banu Madam and Professor Ehtishamul Haq, and also on the surgical side, Dr. Farhana Taran. As we know, the treatment is about the surgery, radiotherapy, and the chemotherapy. And from the slide of Dr. Parvin Banu, we have seen that the most of the patients of our country are used to come at advanced stage, that is in 2B and 3B stage. And here, actually, the chemoradiation therapy is very, very important. And Madam elaborately explains everything nicely. And about the chemotherapy, Professor Ehtishamul Haq also, he explained everything. And the surgical part, Dr. Farhana, she also explained everything very nicely. And we the learners, we the audience, I think we learned a lot from this. So as we have got a huge number of patients, and with this modern facilities of Labaid Cancer Center, and with this updated knowledge of today's session, I think we will be enlightened to improve the treatment of cancer of our country and save thousands of lives. Thank you very much all for attending the session.
Thank you, Madam. Now I am requesting our special guest, our beloved Professor Dr. Sabira Khatun, Madam, Founder Chairman, Department of Gynaecology, Bangabandhu Sheikh Mujib Medical University. Sabira, Madam. Sir, yes, sir.
স্যার আগে বলুন।
জি স্যার, জি স্যার।
জি স্যার, স্যারকে করুন। স্যার আপনি বলেন।
It's a vast subject. Thank you very much for giving me this opportunity and possibly for interrupting your program. But this was getting long, and I've got other program also. Now, cervical cancer, I don't know, you have seen, as I have seen, long time back. When I came back from UK in 1963, there was only one radiotherapy machine in the whole of Bangladesh. That was in Mirzapur, Kumudini Hospital, and they used to give low voltage radiation, which produced severe skin damage. Don't know how much they improved the cervical cancer. So I was lucky, but my professor was also interested. So we started doing radical hysterectomies in this country, in Dhaka Medical College. And I think we could help many patients by this procedure, which was not being practiced in the then East Pakistan. So that was one achievement, and we used to do standard cystectomies, and the results were rewarding in those cases where you could catch the patient in an operable stage. Now about radiotherapy, there's no brachytherapy. So we got some radium needles from WHO to treat cancer cervix by brachytherapy. We had no ovoids, we had no tandems. So we used to take dental stent, which becomes soft when you put it on hot water, and make tandems by ourselves, my own naked hand. And I used to put this radio inside the vagina of the patient and inside the uterine cavity in a rubber catheter. And this way we treated a large number of patients. And nobody actually advised us about the hazards of radiotherapy at that time. We knew in a general way, but later on we became aware, and I'm alive even in spite of this high radiation, possibly because of the blessing of my patients. Otherwise, I would not have survived the radiation, because we are used to handle this radiation, 50 milligram of radium needle by bare hands, and to put it inside the patient's vagina and the uterus. That was a time when, in our own way, we try to treat this patient, give some relief. Because cancer cervix is not only a killer, but it is a dreadful killer. If you have seen this patient in the terminal stages, the death is painful and very undignified, leaking urine, leaking stool, and so on. So this was the situation at that time. Over the years, there has been lots of improvement, as has been described by our previous speakers. And I think now we are just having a bright light at the end of the tunnel for elimination of cancer cells. And you all know, I'll not recapitulate what is the WHO target set. We generally cannot reach our target, but if we try hard, we reach near about it. And eliminate cancer completely, we can go to a stage of near about elimination. So I think the most important advancement that has been made, not only on the technical side, on nature of chemotherapy, the strength of the machines, linear accelerators, and so on, but I think the most important discovery is the relationship between the human papilloma virus and cancer cervix. That is the only way which can prevent this dreaded disease. Universal vaccination must be emphasized for these young girls. Cost is a factor, but it's not so much. But more important is to convincing the people about the utility of this vaccination. And I think that is the big task now. We can treat individuals by our individual attempt, but we cannot treat the whole mass without a procedure like vaccination. So I think whatever we do, we should improve our chemotherapy, we should improve our other types of therapy, radiation therapy, and so on, but go on emphasizing that young girls get vaccinated. In this country, between the 9 and 15 years, their parents should be convinced, and that is the only way by which we can bring down the incidence of cervical cancer. So I think that one is the emphasis that we should do. It is not to say that those who have got the cancer should not be treated. They should be treated in the best possible way, but the prevention is better than that. I think that. Thank you very much for inviting me, and I congratulate Labaid for cancer. Thank you.
আমরা সবাই মিলে স্যারকে একটু থ্যাংক ইউ বলি।
Thank you, sir.
On behalf of Labaid Cancer Hospital, we would like to thank Professor T.A. Chaudhary sir, and we are really elated by his presence in today's webinar. Thank you very much, sir.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, sir.
Now I'm requesting Professor Sabira Khatun Madam to give a short comment regarding this same.
Short comment. The chairperson of this CME session, Mr. Shakif Shamim, Chief Guest Professor T.A. Chaudhary sir, and the panelist Professor Dr. Firdausi Begum, and Professor Dr. Alia Shahnaz, and special guest myself, and Professor Dr. Kazi Mustaq Hussain, and lastly the presenter, the dignified presenter of this session. Thank you. First of all, I would like to give thanks to Labaid administration for allowing this type of CME program, including OGSB. And I myself, being a part of Labaid Cancer Hospital, I'm very much delighted to be a part of this CME session. First of all, I want to say that the treatment part, that is the third pillar of the elimination of cervical cancer, is very difficult. I think it is very difficult for our country, though we have advanced in the theoretical aspect of treatment of the pre-cancer and cervical cancer, but practically I found very disadvantages and drawbacks in the treatment, especially in the treatment of pre-cancer of cervix. Many of the centers are establishing colposcopy machine, but without any facility for treatment of the pre-cancer. But ideally, a colposcopy setup should have a colposcopy machine as well as the treatment facility. And many of the centers establish the treatment facility, ablative procedure facility, without any excisional procedure facility. But as for example, in NICRS, they have got the excisional facility, but without any ablative procedure. So all colposcopy center setup should have the both ablative and excisional treatment facility. And next, the treatment of cone biopsy, some of the patient need cone biopsy for treatment of carcinoma in situ to exclude the invasive cancer, because without knowing the invasive cancer, treatment is incomplete. And many of the invasive cancer patients are treated incompletely. So we should, in our country, now there are many up to 60 specialists, about 60 expert and skilled gynecologists to do surgery for cervical cancer. Even then, many of the cases are treated, surgery done incompletely in peripheral hospital, and sometimes in the center, Dhaka city also. So we have to look after these things. And for Labaid Cancer Hospital, I would like to say that there should be a treatment facility for invasive cancer, invasive cervical cancer treatment, surgical treatment of invasive cervical cancer, as well as there should be a facility for screening for cervical cancer, and as well as treatment of the pre-cancer of cervical cancer. So I think the Labaid Cancer Hospital will be able to do this facility, establish this facility, and ultimately it will be a full-fledged center for both for the prevention and treatment of cervical cancer in the long run. Thank you very much for giving me the chance.
Thank you, madam. Now I am requesting our next special guest, Professor Dr. Kazi Mustaq Hussain sir, ex-director, National Institute of Cancer Research and Hospital, and president of BSRO, to give some comment regarding today's CME.
Thank you. Today's seminar's chairperson, special guests, chief guest and special guest, and moderators and speakers and learned audience. I would like to thank you everybody for attending the session. Actually, these type of session should be confined with some limited slides and limited time. Each speaker, if we have to complete it within 45 minutes, because you cannot concentrate after 40 minutes. So I would request everybody to shorten the presentation in future. Okay, thank you. But the main point is that we have a huge burden of cancer and cancer cervix patient in Bangladesh. We all know this. Number one. Number two, WHO is planning to eliminate, say, cervix from the world by 2120. A 100-year program is going on. It has been started. As a part, we have formulated, or they have formulated, that 90% of the girls will be vaccinated, 70% of the women will be screened, and 90% of the patients should have treatment should have the facilities to get treatment by 2030. Now, where are we? This is the main question to be solved. We know our strength. Our oncologists in total, radiation oncology, surgical oncology, gynae oncology, medical oncology, in total, we will not exceed 300. But we need more than 2,000 as per our population. We need radiotherapy centers around 250, but we have only 26 or 7 centers that have radiotherapy facilities. We have only 39 machines that are working, including all type of machines, but we need 250 machines. So we are far behind the logistic support team to achieve this goal. And it is not possible for government to eliminate the cancer problem, not alone possible for any private center. So we will have to try our best to achieve the goals, and let us hope for the best, but to achieve the trade target, that is to vaccinate 1.4 million, 14 million girls, 30 million women to be screened, and 0.1 million, more than 1 lakh patients to be treated by 2030. We have a huge challenge in front of us. So let us hope for the best and work together to achieve the goal. Thank you.
Thank you, sir. Now I am requesting our participant, if any of our participant give some comment or like any other speech regarding today's CME, because we are heading towards the end.
Thank you very much. I am Dr. Mariam Faruqi. I work in Labaid Fertility Center. So the year was very nice. The seminar was CME program were very nice. It was a brainstorming really. But I just want a request. I want to request, even I talked with Mr. Sakif regarding fertility preservation. Every cancer hospital should be associated with one fertility preservation society, department, or even in the board meeting, there should be an fertility preservation specialist, or even a point to mention regarding the fertility preservation of the patient for both male and female. This awareness should be created, and I'm very much delighted that Dr. Farhana mentioned about the fertility preservation during the cancer cervix treatment. But I think this should be in our mind, especially you people, because a patient come first to you for this type of treatment. And you'll be delighted to know that in the pandemic, we have made a fertility preservation society where many of you attended the programs where our sir, Professor T. Choudhury sir, is the president, and I worked as a general secretary. So I just want to mention about the fertility preservation of the cancer and onco or non-onco patients. Thank you very much.
Thank you, madam.
Thank you, madam. Now I am requesting Amitava Bhattacharya, Head of Business, Labaid Cancer Hospital and Super Speciality Center, to give vote of thanks.
Before that, thank you so much. Before that, I think Dr. Ali Nafisa has raised her hand. She wanted to share something. So I think if Dr. Nafisa could go ahead.
থ্যাংক ইউ, আসসালামু আলাইকুম। আমার আজকের প্রোগ্রামটা আসলে খুব ভালো লেগেছে, যে আমাদের আসলে ফিমেলদের ব্রেস্ট ক্যান্সার অ্যান্ড সার্ভাইকাল ক্যান্সারটা অনেক বেশি আমরা বঙ্গবন্ধু একটা ডাটাতে পেয়েছি। 100 জনের মধ্যে 45 জনেরই সার্ভাইকাল কার্সিনোমা এবং ব্রেস্ট কার্সিনোমা, মানে ফিমেলদের ক্যান্সার ইম্পর্টেন্ট। তো সার্ভাইকাল কার্সিনোমার প্রিভেনশন এবং ট্রিটমেন্ট আসলে অনেক উন্নতি হয়েছে। সেই অনুযায়ী আমাদের যে স্ক্রিনিং ব্রেস্টের ওভাবে উন্নতি হয় নাই। তা আমাদের এখানে যে ল্যাবিড ক্যান্সার হাসপাতাল যে ভূমিকাটা রেখেছেন, যে আমাদের ব্র্যাকিথেরাপিটা হচ্ছে এবং স্ক্রিনিংও হচ্ছে এখানে খুব ভালোভাবে, প্যাপিসমেয়ার দিয়ে আমাদের এখানে করছে, ভ্যাকসিনেশন হচ্ছে। সেই সাথে আমাদের এখানে কিন্তু মানে ব্রেস্ট ক্যান্সার নিয়েও আমরা একটা খুব ভালো সেশন একটা এক্সপেক্ট করছি, যে এখানে যে আমরা স্ক্রিনিং করছি ম্যামোগ্রাফিক বেসড 35-এর পরে খুব আর্লি ক্যান্সার গুলো ধরতে পারছি। এখানে আমাদের রেডিওথেরাপি যারা দিচ্ছেন, আমাদের অনকোলজির ম্যাডামরা স্যাররা যে ফাস্ট ফরওয়ার্ড ট্রায়ালে দিচ্ছেন। তো আর একটা সবচেয়ে জিনিস ভালো লেগেছে, ওজিএসবি কে আমি বলবো থ্যাঙ্কস জানাবো, যে একটা আমাদের গাইনোকোলজিক্যাল যখন ক্যান্সার গুলো ডিল করছেন, তখন অনকোলজির তরফ থেকে কিছু শোনাটা, এটা আসলে খুব বড় একটা ইস্যু। আমি নিজেও অনেক কিছু শিখেছি আজকের একটা প্রোগ্রাম থেকে, যে অনকোলজিস্টরা কিভাবে ম্যানেজ করছে। আমি একটা সার্জন, আমি অপারেশন করছি, এটা একটা বড় ইস্যু। তা আমি আশা করব এটা পাশাপাশি আমাদের নেক্সট সেশনে খুব সুন্দর করে ব্রেস্টের একটা হবে, যেখানে আমরা সার্জনরা অনকোলজিস্ট থেকে কিছু শিখবো, অনকোলজিস্টরা সার্জনদের কাছ থেকে কিছু শিখবে কিভাবে আমরা ম্যানেজ করি। ধন্যবাদ।
Thank you, Dr. Nafisa. I think that was really wonderful. So I am Amitava Bhattacharya. I work here as the head of business for Labaid Cancer Hospital and Super Speciality Center. So today, on behalf of Labaid Cancer Hospital and Super Speciality Center and our Honorable Managing Director, Mr. Shakib Shamim sir, though he could not be present in today's session today, on behalf of the organization as well as on behalf of him, I would like to thank our most respected and honorable Professor Dr. T.A. Choudhury sir. We are really elated to get him today at this webinar. My sincere thanks to Dr. Parveen Akhtar Banu madam, Professor Dr. Itishamul Haq sir, and Dr. Farhana Tarannum Khan madam for the wonderful deliberations and the presentation they made. It was really very educative and academic. I believe the participants of OGSB and all who participated, along with us, we learned a lot of things regarding the management of cervical cancer and the treatment options. My sincere thanks to Professor Dr. Firdausi Begum madam and Professor Dr. Alia Shanaz madam, the panelists, who have been really and wonderfully elated and described the session today. We would, on behalf of Labaid Cancer Hospital, we would like to thank Professor Dr. Sabira Khatun madam, special guest, Professor Dr. Qazi Mustaq Hussain sir. So we are really thankful to OGSB and the authorities of OGSB who has helped us in conducting this program. And on behalf of Labaid Cancer Hospital and Super Speciality Center, we are really honored to have you all today in this webinar. Thank you so much. And yeah, sorry, not to miss the thanks. It was a great moderation, Dr. Shadia Sharmin madam. It was fantastic moderation. So you helped, moderate all these speakers very well. So on behalf of Labaid Cancer Hospital and our managing director, we once again take the honor and privilege to thank you all for joining us in this webinar. Thank you so much.